With that, I'll hand it over to Dr. Lyle.
Great, thank you so much. And I'm going to also talk fast in the interest of time because we have our last but not least session. We're going to do some speed talks on some really important work that's been done at Stanford. And I'm going to introduce each speaker, have them speak, and then introduce the next one. So first, we have Dr. Irogue Igbinosa. She is a women's reproductive health research scholar and maternal-fetal medicine physician at Stanford. Her research interests include anemia in pregnancy, severe maternal morbidity, health disparities, nutrition, and infectious diseases in pregnancy. In her recent peer-reviewed article entitled Racial and Ethnic Disparities in Antepartum Anemia and Severe Maternal Morbidity was featured in the Green Journal's special interest on special issue on racism and reproductive health, and she was on the podcast, and it was a very big deal. She's a co-investigator in our U54 project on anemia, the one entitled Patient-Centered Community and Clinical Approaches to Reduce Racial Disparities at Birth by Preventing Anemia. And she's involved in several hospital-wide quality improvement initiatives aimed at reducing health disparities and improving health outcomes. And it has been a great honor of my career to serve as one of her mentors and knowing her since we first met over 10 years ago. She's the PI for the randomized controlled trial assessing IV versus oral iron to treat anemia during pregnancy, and that's what she'll discuss tonight. So, the floor is yours.
Thank you. Good evening, everyone. And thanks for that introduction. Let me set up slideshow, cancel, sorry here. Okay. Can you see? Yeah.
Yeah, we're looking at presenter view.
Okay. Let's see. Sorry.
Go. Eero at the top. See if you say swap displays, if that will do it.
Let's see here. I have two screens, so I need to take off the other screen. Oh, I see here. Okay, perfect.
There you go.
You can see the right thing. Okay, thank you. All right. Good evening. I'll be talking about the prevention of antepartum anemia at the time of birth admission. I have no disclosures. And first, I'll start off with some just kind of reviewing severe maternal morbidity, unexpected outcomes of labor and delivery that result in significant short or long-term consequences to a woman's health. And for every maternal death, greater than 100 women experience severe maternal morbidity during their delivery hospitalization. And so this is some data that I know many of you are familiar with, but this is out of the California Department of Public Health that shows severe maternal morbidity has been increasing over the past several years, and the disparities have been persistent with Black pregnant women, pregnant people, often, unfortunately, having the highest rates. And the SMM is defined by the CDC with 21 plus indicators of diagnosis and procedure codes, often of which blood transfusion is a significant driver for. And so a lot of my work, as many of you know, is with anemia, and it's because anemia is strongly associated with transfusion rate, a driver of SMM. And in this report, it kind of just shows even at the mild levels of anemia, there's an increased risk of transfusion. And as that severity of anemia increases, so does the risk of transfusion. And so that kind of leads to the question, how prevalent is antepartum anemia? It's about 20% of pregnant people in the United States, 40% globally. 80% of anemias in pregnancy are due to iron deficiency. In this graph, it shows the cutoffs may differ. So in the US, we use ACOGS, which is the CDC definition with the 5th percentile, where we have different cutoffs by trimester, less than 11 of a hemoglobin in first and third trimester and 10.5 in the second. Whereas internationally, most use the WHO, where it's a singular cutoff of hemoglobin less than 11. And then about a third of pregnant people in the United States are considered iron deficient in the first few weeks of pregnancy. And so some of our recent work was looking at the trends of anemia in California and stratifying by race and ethnicity. And you'll see that our trends kind of mirror that you just saw in the severe maternal morbidity. And so a lot of our work has been looking at how much does anemia contribute to SMM. And in this, I'll just kind of summarize, we found that anemia contributes anywhere to about 1 in 5 to 1 in 6 cases of SMM, which variances by race and ethnicity, with Black and Hispanic pregnant patients often having the higher contributions of anemia to severe maternal morbidity. And then there's also recent literature, not from our institution, but out of Texas, that shows that patients who are refractory to anemia, meaning that they received oral iron, but did not receive IV iron, did not receive achieve a hemoglobin greater than 11 at the time of delivery, had an increased odds for blood transfusion risk. And then just to kind of wrap that up, what are our standards? As many of you know, our standards are oral iron, regardless of gestation. However, it's flawed. Over up to 70% of patients can have side effects, most often GI. And IV iron use is not standard in U.S. obstetric clinical care. And our guidelines have wide variability. The United States Preventative Task Force says it's inconsistent evidence to make a recommendation. ACOG says it depends on the physician if the patient is able to tolerate or has malabsorption. And then Royal College of Obstetrics and Gynecology in UK says every patient with a hemoglobin less than 10 at 34 weeks or greater is eligible for IV iron. And so there are pros. We know it can be quicker, but there are cons because of the length of treatment, visits, adverse reactions, and cost. And part leading to our trial, there are newer formulations with less anaphylaxis that are not studied in obstetrics. And so one of the gaps that our study looks at address is, will IV iron, mainly we chose femoxetol, which reason I can explain offline, more effectively address antepartum anemia in pregnancy? And then long-term, our question is, will treatment of antepartum anemia decrease severe maternal morbidity-related outcomes? And so that is our hypothesis, that with treatment with femoxetol, particularly in the later half of the pregnancy, 24 to 34 weeks, that will more effectively resolve anemia at the time of delivery. And at the time of this study, there were no trials using femoxetol in pregnancy. And since then, looking at clinical trials, there's been one. And then the other thing that we will look at is, what are the patient-reported experiences and quality of life with each study arm? Our inclusion criteria: patients 18 and older, singleton pregnancy with iron deficiency that is confirmed, which is important, especially when we're giving IV iron and dosing it. And then our exclusion criteria is essentially anything that is a hypersensitivity or oral iron is precluded because of malabsorption. And so we are randomizing patients based off severity, hemoglobin 9 to 10.9 with oral iron versus 1 dose of IV femoxetol. And this is based by an extrapolation of the IV iron dosing based off of average deficit, and then hemoglobin 7 to 8.9, and where that's a higher dose of oral iron, 2 tablets every day, 650 versus femoxetol, 2 doses. And that's it. Sample size is 80 participants, and we currently have 72 enrolled. So thank you, everybody. Thank you for helping us recruit. And then we have a data safety monitoring board that meets biannually, and our analysis plan is intention to treat and per protocol analysis. And then for our patient-reported experiences side, we have been using a validated survey, which is basically, these are the domains. And we do it pre and post treatment. And for those on the oral arm, we do it every 4 weeks until delivery, just to compare how, like, their general symptoms. And so our ongoing work and next steps is to include enrollment in the pilot trial. We're anticipate to be done winter 2024. And long-term is community-based partnerships to understand patient experiences, and a pragmatic trial to examine the impact of a comprehensive anemia intervention on decreasing SMM. And with that, I would like to say thank you to my primary mentor, Dr. Lyle, as well as co-investigators who've worked on this project, as long as several others. And then I've listed the funding for this trial specifically is our Maternal Child Health and Research Institute. And with that, I'll take any questions.
Great. Thank you so much, Iro. Yeah, we're running short on time, but I do want to throw out one question as Ijeoma and Janet pull up their slides, if they have them. And we look forward to hearing your results next year. Can't wait to to see them when we're done with this. But what's been the greatest challenge in running this RCT? Because tonight's about RCTs, and I think just for other trainees on this.
I would say one of our biggest challenge is how people kind of interpret the guidelines. And so like we see things and we see that that we assume that certain things are happening in screening, and there's just a lot of variation in individual practice. And so how do you anticipate that? And so really just trying to get people on board to understand why we should kind of actually confirm iron deficiency, why that's important, and then actually track it. And so I think as we've gotten people on board, that's been more exciting and rewarding.
So it kind of harkens back to what Allison Cahill said at the beginning about implementation and kind of that concept of just educating people, because people are kind of entrenched in their ways. So even getting people to agree to doing what we need to do to get them patients randomized has been important. Thank you so much. In the interest of time, and I'm sorry that we are limited, but I'd like to introduce Janet Hurtado and Ijeoma Iwekaogwu. Janet is a CRC associate within MFLB, the research team, and has coordinated several studies related to gestational diabetes, congenital heart defects in pregnancy, fetal therapy, placenta accreta, allergies and microbiome, maternal mental health, and so many more. In addition to her passion for clinical research in women's health, she's also dedicated to mentorship and increasing the representation of underrepresented minorities in all fields of medicine. Ijeoma Iwekaogwu is a CRC2 within our MFM research team, and she's coordinated and worked on research related to preeclampsia, cardiac disease and pregnancy, placenta accreta, and randomized the RCT that Iro just presented. She's currently a project manager for the U54 project on anemia as well, and we're so excited about that. And together, Janet and Ijeoma will present a day in the life of a CRC.
Hi, everyone. Thank you for joining us tonight. So I'll just be going quickly through the slides as well. But to get us started, the responsibilities of a CRC are very, vast. We have complex role where we have to be able to juggle a lot of different tasks for many different studies on any given time. So I would say since Ijeoma and I have started, we have coordinated anywhere from 3 to 6 studies at a time. And I like to describe the role of a CRC as we are the methods section of a manuscript. We are tasked with recruiting, enrolling, collecting the data, and many other tasks, as you can see listed here. Something in particular that is unique about being a CRC here with MFM is that we have on-call. So as many of you may know, we collect cord blood for many of our studies, and getting the cord blood can be, a daunting task, because in pregnancy, women can deliver whenever, wherever. So we do have our whole team. We have a schedule where we have a 24 on-call system, and we coordinate cord blood collection at any given time of the day. An additional thing that's unique to MFM is that we're a very interdisciplinary research team. So many of our studies, as we have listed here, are actually in collaboration with different Stanford departments, such as the Shannon Parker Allergy Center, the Gardner Research Group, anesthesia, neonatology, and many more. And so some of the research studies that Ijeoma and I have worked on recently, as listed here, it includes Iro's anemia study, and then Scarlett's FIFO moms study, which we just finished recruitment for not long ago. And so for recruitment, enrollment, and retention, when do all these things happen? It just depends on when the inclusion criteria wants us to enroll participants. It could be anywhere in the first, second, third, or postpartum timeframe. We recruit from everywhere here at Stanford where pregnant people may be, OB clinic, gyne clinic, labor and delivery, antepartum, postpartum. And even recently, due to COVID, everything or a lot of things had to go online. And so we started advertising our studies on social media. And we've found great success with study pages for moms in particular. So how do we retain a lot of these moms? As Dr. Maldonado actually explained earlier, we have a lot of similar challenges with retention, with people just not having enough information about the studies or the different things that we're trying to look at. And so to maintain retention, it is key for us to maintain regular communication throughout the study with our participants. So we do give them phone numbers to access us, or emails, so that they feel comfortable, calling us, texting us, emailing if they have any questions. We try and be as supportive as possible so that they feel comfortable talking to us and coming to us if, they can't meet a deadline, so that we could be flexible with them to retain them in our studies. Sometimes we use gift cards to, offset whatever they have to spend on, driving to the clinic to get a blood draw or to make it to a study visit. And most recently, what I've learned is that a lot of our participants are just interested in knowing the results. So for moms in particular, we have been releasing data to them so that they can see what's happening in their body. And it is planned to give them a comprehensive package at the end of the study, showing them how their microbiome changed and was passed on to their baby after delivery. I'll pass the torch on to Ijeoma.
Thank you. So there's countless of highlights that come with working with the patient population that we do. We spend a lot of time with patients from the informed consent process to really long research visits, and this extended time really facilitates the building of this strong rapport between us coordinators and participants. And this really goes a long way to create a supportive and trustworthy environment that Janet mentioned. With these study visits come extra monitoring with extra laboratory testing, and this really gives a lot of patients relief. For the anemia RCT I work on, we routinely check patients' CBC at different time points to see if the current treatment is improving, and if not, we really just collaborate with OB providers to determine the best course of action to improve patients' hemoglobin levels by the time of delivery. And lastly, the trickle-down wealth of knowledge from provider to coordinator to patient is a pro with clinical research. Dr. Igbinosa has instilled so much knowledge about all things iron deficiency anemia, which has really enabled me to pass on this knowledge to participants, and this enhances their sense of agency and involvement in the research process on why research is really important and how their contributions go a long way to benefit other pregnant people and their babies. But also, recruitment of pregnant women in our research studies come with its own set of unique challenges. There's so many factors that can influence recruitment. Most declines from patients are chalked to being too busy. They have too much work priorities, lack of transportation, other pregnancy problems in general, research perception and distrust of research in general, and opinions of partners that discourage active participation. In general, another challenge is to highlight, how do we make sure that research is equitable and representative of our patient population? It's something coordinators heavily bear in mind when it comes to recruitment. In a perfect world, we could recruit patients that represent every race, ethnicity, speak every language, but we're really limited by the patients that we see in clinic spaces. And that's why it's really important that we try to engage with the community to recruit patients of all these criteria. And then the next bit is informed consent. There's a long section about risks, which reserve careful thought, and we can't predict the potential impact on their babies, so patients have to decide if the study benefits outweigh the risks. And the last bit is retention, in which Janet mentioned. Despite our best efforts, patients are lost to follow-up, and we have to ensure that we try to enroll enough patients for power when thinking about data analysis. And the last slide is how can providers help us clinical research coordinators? In our commitment to excellence, we collaborate closely with esteemed faculty members who play a pivotal role in guiding and supporting us research coordinators. So engagement is a really critical component for recruitment. Participants are more likely to sign up for our studies if it has been recommended by their healthcare providers. That, of course, is not the principal investigator. So shout out to all the providers that encourage our participants to be a part of our research study. And lastly, recruiting research patients take time. So give us patience with the process and know that we're doing our very best to meet these enrollment goals. And with life, all great things come with time and patience. Thank you. We're really grateful to be in this space.
Great. Thank you, both of you. We're getting lots of kudos to both of you, and I second that we are so lucky to have both of you and all of our awesome research coordinators. And we really, truly couldn't do this work without you. You guys are the critical glue that makes these studies possible. One question, as Hayley pulls up her slides, because we are running short on time, is what qualities would you like to see in all PIs? I mean, you talked about the providers, and that's a very important point for all the providers on the line, that that's provider support is key, but you're working a lot with the PIs as well. And what qualities should we all keep in mind that would be important in working with CRCs?
I think really just being available if we have questions, which a lot of you are great with doing, whether that's a quick phone call, an email, or a text. I think that goes a long way.
Great. Well, thanks again. In the interest of time, we're going to move on to Dr. Hayley Miller, who's a current third-year maternal-fetal medicine fellow at Stanford, where she also completed her OBGYN residency. And as a fellow, Dr. Miller is focused on the intersection between MFM and complex family planning. Locally, she serves on many committees, the L&D Local Improvement Team, Perinatal Loss Committee, and the Reproductive Health Privacy Committee at Stanford, very important. She's also been active in ACOG regionally and nationally, serving as the Junior Fellow Chair of California, currently the Chair of the Public Health Committee, a member of the Committee on State Legislation and the District 9 Advisory Council. She's also a member of the SMFM Health Policy and Advocacy Committee. She's received grant funding to assess the use of Mifepristone for term induction of labor, the focus of her MFM fellowship thesis, which she'll present today. So, Dr. Miller, the floor is yours.
Thank you so much for that welcome. So yes, I will be presenting on Mifepristone as an adjunct to transcervical balloon for labor induction, which is the MiLI trial. So induction of labor is a topic that has captured the interest of healthcare providers, patients, researchers, and policymakers. I want to start by defining induction of labor, which is the stimulation of labor for the purpose of accomplishing a vaginal birth. Induction of labor is warranted when the benefits of expediting delivery outweigh the risks of continuing the pregnancy. For example, in the setting of preeclampsia or other chronic conditions that we see. More recently, the discussion of elective induction of labor following the Arrive trial has gained attention and popularity nationwide. So overall, the goal of labor induction is to facilitate cervical softening, thinning, and dilating. Changes include collagen breakdown, increased production of cytokines, and white blood cell infiltration. The actions of progesterone on the pregnant myometrium include relaxation of myometrial smooth muscle, blocking of the action of oxytocin, and inhibition of the formation of gap junctions. And in animal models, a decrease in plasma progesterone and an increase in circulating estrogen precede the onset of labor. In addition, administration of progesterone antagonists, for example, Mifepristone, in people at term results in an increased rate of spontaneous labor. For those who are unfamiliar with the process of induction at LPCH, the birthing person is admitted to labor and delivery. The OB team establishes the medication or method to prepare the cervix for induction of labor. And in most cases, a vaginal delivery follows induction of labor. According to ACOG, the Practice Bulletin of Induction of Labor in 2009, 25% of gravid people undergo an induction of labor. In 2018, a large randomized clinical trial, the Arrive trial, revealed findings to favor elective induction over expectant management at term. This trial has influenced national rates of induction of labor, and we have seen a steep increase in the incidence of labor induction. Institutionally, LPCH has recognized the impact of this change in practice. Currently, 40% of spontaneous vaginal deliveries follow induction of labor at LPCH, with an average induction time of 20 hours. This mean duration has been consistent when comparing institutional data from 2005 to 2020. With increasing labor induction incidence and long durations of labor, labor and delivery beds are occupied longer, hospital costs are increasing, and medically indicated labor inductions are delayed. Robust evidence has helped to guide improving the induction process. Cervical preparation is an integral part of labor induction, and induction of labor begins with cervical preparations, including medication and mechanical options. But labor induction times have substantially been unchanged over time, and despite thousands of quality research studies. With that being said, there's a new need for methods and models to decrease the hospital induction times. This leads us to Mifepristone, a medication most of us are familiar with. And this is a progesterone receptor antagonist, and it's included in the World Health Organization list of essential medications and is FDA approved for first trimester medication abortion, but is used off-label for second trimester medication abortion and induction for stillbirth, and is known to reduce the time to delivery by 40 to 50% when used in conjunction with misoprostol. So just pharmacokinetic standpoint, progesterone inhibits contractility of the uterus. Mifepristone has the potential of inducing labor through its actions in antagonizing progesterone, thus increasing contractility and increasing the sensitivity of the uterus to the actions of prostaglandins. And this could serve as an excellent cervical preparation method and has been studied previously. However, this has been studied internationally. Outcomes of these studies showed that compared to placebo, people treated with Mifepristone had a more favorable cervix. They're less likely to have a cesarean birth, or were less likely to need augmentation with Pitocin, with no difference in neonatal outcomes. In a recent study, Mifepristone was compared to a Foley balloon, and the primary outcome showed more vaginal births within the first 24 hours when a Foley balloon was used when cervical preparation compared to Mifepristone. So interesting studies are underway, however, not in the US. So understanding the pharmacokinetics of Mifepristone and the previous research done internationally, we sought to understand its use within our local labor induction landscape. And we performed the MiLI trial, which is a pilot study that's 2-arm randomized control trial of nulliparous people induced with a transcervical cook balloon, comparing perinatal outcomes among patients who received Mifepristone versus misoprostol. The study design was parallel group, 2-arm, non-blinded, superiority randomized control trial with 15 people in each arm. And the aims are really to generate preliminary data on perinatal outcomes and examine recruitment feasibility and willingness of participants to be randomized to guide recruitment periods for future studies. These are a number of the obstetric outcomes, but our primary obstetric outcomes were the number of uterine contractions, rate of uterine tachysystole, and category 2 fetal heart tracing. This was derived by understanding the pharmacokinetics of Mifepristone. We know that Mifepristone primarily is used as a cervical preparation and theoretically more softens the cervix and prepares the uterus for uterine contractions. And we know that misoprostol acts both on the cervix and causes uterine contractions. So we know that by stimulating the uterus, there's a potential for tachysystole and subsequent fetal heart rate changes. So we sought to assess these outcomes in an inpatient setting as a pilot study to inform future studies. These are among some of our neonatal outcomes, which really compared cord gases, neonatal APGAR scores, and a composite of neonatal morbidity. Overall, we included people that had uncomplicated pregnancies between ages 18 and 45, and we only included singleton term births. We excluded complicated pregnancies. This is a list of many, and pregnancies with contraindications to vaginal birth. In our study, we screened 2,556 people. 330 people were eligible. We enrolled 30 people, and people were excluded based on the practice which they were included. For example, we included PAMF, San Mateo, and Stanford patients, but other private practices were excluded from the study. And actually only 33 people declined, and 13 people consented for prospective chart review as an alternative to the randomization. I will be presenting the results at SMFM, so stay tuned for February. But for future directions, there really is a need for new methods and models to decrease hospital induction times, and outpatient methods are really the way of the future. We performed this pilot study in hopes to generate preliminary data to inform future studies on assessing Mifepristone as an outpatient regimen. And Mifepristone, however, legislation really may pose barriers to advancing labor induction methods. This study, there was a federal abortion or Mifepristone ban for a day during our recruitment. And really, ACOG just sent this out last week, as restrictions are making Mifepristone difficult to access for miscarriage management. So certainly something that is worrisome for helping induction of labor, especially knowing the pharmacokinetics of Mifepristone really may advance cervical preparation. And just to summarize, there are other outpatient methods being used. We don't recommend them at this time due to insufficient safety data, but there has been robust studies out of Kaiser and other institutions about misoprostol as an outpatient and cook balloon. Certainly something that we're hoping to understand more safety data on. Thank you to MCHRI for the grant funding and the collaborators of my study, which are listed here, and to our wonderful CRCs who helped screen the over 2,000 patients.
Great. Thank you so much, Dr. Miller. We look forward to your bringing the results to next year when to this meeting. As our next speaker, Dr. Nguyen, pulls up her slides, do you have how did the ban? I mean, it was one day, the ban, but there was a lot of lead up to it. Did that affect the study at all?
I would say it was challenging to recruit patients for a brief period of time, especially when this was a very highly publicized medication. Certainly, the CRCs and myself had a challenging job to really discuss all of the safety data. But ultimately, we did enroll the 30 patients that we were hoping to enroll in the year. But certainly is something worrisome for the future for outpatient studies, I think. But safety data has been generated, so hopefully this will inform us.
Thank you all to our speed speakers, and sorry it was speedier than intended. And thank you. I'm going to turn it over to Yasser right now for final words.
Well, thank you everyone for hanging in there. This I think was really demonstrated the depth and breadth of the amazing clinical trials work we have going. So thank you to all our presenters and our moderators. Special thank you to Rebecca and Anna, who really led this effort to put this symposium together. It would not have happened without their leadership. Lots of good things ahead. We do this, every several months. We highlight a domain in the symposia, and so lots more to learn, and looking forward to our future achievements together. Thank you all, and have a wonderful night.